Hello and welcome to our DECERA Clinical Education podcast channel, bringing you the latest studies and insights in HIV care for treatment-experienced people. Today's episode, we're looking beyond viral suppression. We're exploring immune recovery, inflammation, and more. If you want details about all the studies that we're discussing today, you can go to the show notes and click on the expanded slide set. But I'm really excited to get things started with our two faculty. Let's turn things over to Dr. Princy Kumar.
My name is Princy Kumar, and I'm an infectious disease attending in Georgetown University in Washington, D.C. And I'm really pleased to be here on this podcast with my esteemed colleague, but most importantly, my friend, Dr. Charlotte Rolle. Can I turn it over to you now to introduce yourself?
Thank you so much, Dr. Kumar. And I'm so excited to be here with you today. By way of introduction, my name is Charlotte Rolle. I'm an adult infectious disease physician and the Director of Research Operations at the Orlando Immunology Center in sunny Orlando, Florida.
Thank you. Today, what we want to do in our podcast, Dr. Rolle and me, is to really look beyond viral suppression. Because we know when people with HIV achieve an undetectable viral load, but the CD4 count remains low, like typically below 350, we refer to them as immunological non-responders. We have a better understanding now that while undetectable equates untransmissible, and that is true regarding transmission, the lack of immune recovery presents several long-term health risks. And that's something that both Dr. Rolle and I have a great deal of interest in. And what are those long-term health risks? They are like increased risk of clinical events, chronic inflammation, higher incidence of non-AIDS defining events. And I'm going to ask Dr. Rolle also to share her perspective on this. But one of the things that struck me was recently I saw an article in Journal of Infection, just published in 2025, it was a systematic review and a meta-analysis, and it looked at 15 different studies and found that individuals with a CD4 count greater than 500 and looked at those with CD4 count less than 200, and people living with HIV with CD4 counts less than 200 had a 7-fold higher risk of AIDS-defining events. We also know that the number of days with a low CD4 count is actually one of the strongest predictors of non-AIDS defining cancers. So I really want to, Dr. Rolle I learn a lot from her about these events. I want to turn to you and say, what do you see in clinical practice?
Yeah, thanks so much, Dr. K. And I think you hit it spot on the head. These comorbid conditions, both the AIDS-defining events and the non-AIDS defining events that you spoke about, they're both accentuated and accelerated, right, in our patients, despite the achievement and maintenance of viral suppression. And I think that both of those things are true. They occur more frequently and they occur earlier in people with HIV overall. But then you're right. When you look at this group with the low CD4 T cell count, we see an even greater emphasis on both of those points, right? Accentuation and acceleration of comorbidities. And I think what we are starting to learn and realize, and in our podcast, so aptly named Beyond Viral Suppression, is that these are folks that are still experiencing a lot of chronic inflammation, Dr. K. And this is, as you said, a great area of interest in our field. It is of great interest to me personally, because I am personally interested in the fact that even despite viral suppression, there is still probably the low-level production of potentially both virus and viral proteins themselves, Dr. K, which are playing a very distinct role in driving this chronic inflammatory state that is leading to both the increased comorbidities and this gap in morbidity and mortality that we see in these two groups of patients, those with CD4 count greater than 500, and then those who persistently have a lower CD4 T cell count less than 200. And so I'm excited that our field is moving towards trying to figure out what is driving this gap And is there any intervention that we can do beyond the control of, lifestyle modification, beyond what we already know we're supposed to do? Tell people to stop smoking, reduce their weight, live a healthy lifestyle. What are some of the other interventions that are available to us that really can help us to try and close that gap between these two groups of very distinct patient populations that we all see in our practices?
I think this will be a good time for us, like you rightly said, beyond lifestyle modifications, beyond viral suppression. What are the effects of we have three drugs that have been approved for highly treatment experienced patients. And these are the patients that started off with very low CD4 counts, remained with very low CD4 counts. So why don't we'll take fostemsavir, because there's a lot of data right now on, and you yourself have been one of the pioneers in this, to look at CD4 cell recovery with fostemsavir, especially in highly treatment experienced patients. So clearly, fostemsavir is a GP120 directed attachment inhibitor, and it's a prodrug of temsavir. And the thing is, the temsavir binds directly both to membrane-associated GP120 and soluble GP120. And during this podcast, you'll hear both Dr. Rolle and me talk a lot about soluble GP120, because we're very excited about what we now know about what soluble GP120 actually does. So when temsavir binds to this, it locks the GP120 in a closed conformation, and this then prevents the virus from initially attaching to this host CD4 receptor, and then it effectively blocks the first step of viral entry. That's why we call it an attachment inhibitor. So that mechanism we knew for a long time. What is more interesting right now is what we are beginning to understand about the effect of uh, temsavir on the soluble GP120. And what we know now is a soluble GP120 can float around even in people that are completely suppressed. And it can go and attach itself to healthy T cells, healthy CD4 cells. And it then causes antibody-mediated cytotoxicity. And you, Dr. Roll, you have done a lot of work on this. I've heard you present, and I've learned a lot from hearing you speak about that. Why don't you go through us the exact mechanism of how it does that?
Yeah, sure, Dr. K. Wow, you really, really are rocking my world right now, because I love talking about antibody-dependent cellular cytotoxicity. And you're right, absolutely, that one of those viral proteins that I mentioned earlier is that soluble GP120. We're learning so much more about that molecule, its expression in both undetectable patients and patients who have active viremia. So why don't we talk a little bit about ADCC, which is how you might hear me refer to antibody-dependent cellular cytotoxicity. So HIV-infected CD4 T cells, we all know that they have the ability to shed soluble GP120. And as you said, it floats around. The issue, though, Dr. K, is that soluble GP120 can bind to the CD4 receptor on completely healthy, uninfected cells, right? And induce conformational changes. It's those conformational changes that we believe mediates this response, in which antibodies are able to recognize that conformation when that soluble GP120 has bound to that healthy CD4 T cell, and then subsequently targets that CD4 T cell for destruction by the immune system. And so we have this bystander killing effect that is constantly leading to CD4 depletion, even in those patients, like you said, who are virally suppressed. And we think that this is probably the main mechanism driving poor immune recovery in those folks you refer to as immune non-responders.
Excellent, Dr. Roll. So, that is what has been proposed. Why don't you tell us, that there's been recent publications that have come out. And if you look at it, a lot of it is from Andreas Fenzi's lab in Montreal. And there was a publication recently in Journal of Infectious Diseases. Why don't you go through that with us to tie it to the concept that you just outlined, the work that was done by?
Yeah, sure, Dr. K. So Dr. Princy is really, I think, the leading researcher in this area. So much of what we've learned about soluble GP120 does come out of the work done by his lab. And so you were right. There was a recent publication in JID from 2025 that looked and tried to pinpoint exactly which antibodies are responsible for this ADCC mechanism that I talked about, and what is the impact of fostemsavir on those antibodies, right? And so basically they took 3 groups, one of which was from the BRIGHTE study, which I know you're going to give us the latest and greatest from the BRIGHTE study shortly. They also looked at folks from the Prestigio registry treated with fostemsavir and used a control group from the SAILING study, which is basically a study focused on the treatment with dolutegravir in heavily treatment experienced adults. And what they found, Dr. K, here was the bottom line. The bottom line was that they were focused on this particular group of antibodies that they refer to as CD4-induced non-neutralizing antibodies. They had done prior studies which have demonstrated that this group of antibodies, the primary group responsible for that ADCC mechanism and ongoing CD4 depletion. And what they found in the 2 groups of fostemsavir treated patients was a significant decline in those anti-GP120 CD4-induced non-neutralizing antibodies. They did some functional assays, Dr. K, in which they observed less ADCC occurring with fostemsavir treatment and a subsequent increase in CD4 T cells. And so it was a great paper because we had the basic mechanism and then we had the functional assays kind of correspondingly showing, okay, yeah, we do block that antibody-induced cellular cytotoxicity. Okay, yes, we have seen that lead to CD4 recovery. And so it was a really pivotal study. It got a lot of press. And I think it's really work from this lab that's driving our understanding and allowing us to design other clinical studies to really hone in on this mechanism.
Dr. Rolle, I'm so glad that you have explained that immunological basis. Most of us have forgotten all of this. So I'm so glad you've explained it so nicely to us and in a way that we can understand. But I was hoping I could add the clinical relevance of this, and that it's really what we saw in BRIGHTE. As most of the people hearing this podcast will know, it's one of the largest global multi-center phase 3 study that looked at twice daily fostemsavir plus an optimized background therapy in adults with multi-drug resistant HIV. And the study is still ongoing. In October, Dr. Aberg presented at the European AIDS conference a 7-year data. I'll briefly review the study with you and really highlight, that really looks at it clinically what Dr. Rolle just presented to us. So right now at year 7, we still have participants still enrolled in the study. And right now we have a total of 80 participants that Judy Aberg presented the data on behalf of the other investigators. And out of these 80 participants, there are 72 in the randomized cohort. And out of this, 83% of them still have sustained virological response at year 7. But what really was of equal interest is that the immunological, the CD4 count recovery did not plateau. It kept going up. And at 336 weeks, that is at 7 years, in the randomized cohort, there was a mean increase from baseline of 357 cells. And then for people who are very interested in CD4 to CD8 ratio, because we have known that this ratio is a key marker of immune health, and other data have shown that it correlates with a much lower risk of death and non-AIDS illness if you have a ratio above 0.45. And what was shown in the 7-year data is in the randomized cohort, the CD4 to CD8 ratio increased from 0.20 at baseline to 0.66. So it is above the 0.45. So I think that was very meaningful as well. And also, there were no new signals that there was any additional side effects. The other thing that interested me is for those who survived to year 2, the mortality risk dropped to levels comparable to a general aging HIV population. And remember, this was for highly treatment experienced patients. So now with what Dr. Roll explained even to me, then I'm better able to understand this persistent increase, slow but steady increase in the CD4 count, and that it has not plateaued. And a lot of this may be related to the effect of the pro-drug of fostemsavir on the soluble GP120. At least I've learned from you, Dr. Roll, is its effect on the soluble GP120. So from the clinical perspective, is there anything else you want to add to the data that I just presented?
Sure, Dr. K. No, I think that was a beautiful walkthrough of our most recent update from BRIGHTE, that 7-year data. And you know what I will say, Dr. K? I will say that it always fascinated me in the BRIGHTE study that we observed increasing CD4 T cell counts despite ongoing viremia, right? Because not everyone in BRIGHTE achieved undetectable viral load, but we still had subgroup analyses from that study in those with ongoing viremia that showed a very significant mean increase in CD4 T cells. And that's just not something that you see in our field very often, where someone is having ongoing active viral replication, but yet their CD4 is still steadily rising. And I think that that caught a lot of our eyes, and we were like, whoa, like what is going on here, right? But you're right, maybe it is all tied into that soluble GP120 and the effect of fostemsavir on that molecule that has been so elegantly studied by Andreas Binci and his staff. Another thing about BRIGHTE that I think is so interesting, Dr. K, and I was wondering what you thought of this, what you made of this, and what's the latest on this, is that you may recall there were 2 groups of viral responders in that study. We're looking at the entire study cohort. There were those that responded really quickly, basically achieving undetectable viral loads within 8 weeks of initiating fostemsavir treatment. And then there were this so-called group of late viral responders, right? Those guys that took a really long time to suppress beyond 8 weeks. Has there been anything new on those 2 groups and what may have been driving that difference in treatment response timing that we saw?
You know, Dr. Roll, there was data presented by Dr. Weiss, and the senior author was Dr. Chen, and was published in Antiviral Therapy in 2025, which is just great. And this early responders are, like you said, who got their viral load down quickly. Late responders took like forever to respond. And what they found is 2 big things. People who started off with a very high viral load took longer to respond. But that does not come as a surprise to us. We have seen that. But I thought what was very, very interesting is they also noted that people with low anti-envelope antibody levels experienced a delayed virological response. And the theory that they gave behind it, they gave a little theory behind that, is that it's really the mechanism of action. It's the way it attaches itself to the GP120. And so if you have a low envelope antibodies, then the drug has to work by itself. There's nothing else to help it to work. So that's how they hypothesized it, is there's nothing. It has to just do all the work by itself because there's no anti-envelope antibody. So I thought that was very fascinating. But equally fascinating to me is that even if it took longer to people still suppress, not to give up, is to keep continuing. And I also thought it was fascinating that people with the lowest CD4 count had some of the highest CD4 count increase. I thought both of those 2 points to me as a clinician was the fact that you may take longer to respond, but not to give up, to keep going, to make sure they're adherent to therapy as long as they don't have toxicity. That as a clinician, that was very important. And I was very happy to see that people with the lower CD4 count normally will think, oh, they'll never recover. did have some of the highest CD4 count increase. So I thought that was very, very fascinating. And I was hoping that you could tell us at ID Week, I think your presentation was one. Clearly, I'm biased because I think you walk on water, but was your recover study. So would you tell us a little bit more about that?
Yeah, sure. Thank you, Dr. K. So we were really pleased to have some preliminary data from the Recover study to present at ID Week. And then just for those who are not familiar with the Recover study, it's basically a phase 4 study. It's a self-controlled case series where folks are serving Dr. K as their own control. Okay, so we took a group of immune non-responders, as you mentioned. Those are folks traditionally defined as folks who have achieved viral suppression but have never been able to get their CD4 count above 350. We took 25 patients in our entire cohort. Our ID Week presentation included data from the first 23. And we simply added fostemsavir to their suppressive regimen and just looked to see what happened. And when I say that everyone served as their own control, Dr. K, what happened to their CD4 count in 48 weeks with fostemsavir on board? We simply compared that to the pre-fostemsavir values from 2 years prior to study entry. And so we were very excited. It's a small sample size, again, data from our first 23 patients. But even with those first 23 patients, Dr. K, we have already started to see a statistically significant increase in CD4 T cell count when you compare it to the pre-fostemsavir values. And that's, doing some fancy change of slope analyses that our statistician did. But needless to say, we were excited about that. We acknowledge that 48 weeks is a really short amount of time. And so it was exciting to kind of see that change in such a short amount of time. We also looked at the proportion of folks that then went above 200 because we had a very significant proportion of our patients start with CD4 T cell counts below 200. And then one of our other outcomes was proportion with CD4 T cell count above 350. And you mentioned that that is one of, an important benchmark that we really try to achieve for our patients because of that reduced risk of AIDS-defining and non-AIDS-defining events. And we had about a quarter of our patients actually achieve that benchmark in the study. So it was exciting preliminary data. Our study is now fully enrolled, Dr. K, and our last study visit scheduled for some time in February. And so we're excited to get the data from the full cohort out there to you guys soon. One thing I do want to say about the Recover study that I want people to know is that there is a biomarker sub-study that is being done in conjunction with Andreas Vinci and his lab at the University of Montreal. They're going to be looking at soluble GP120 levels in our Recover patients and seeing if there is a correlation between those levels and the response to fostemsavir and CD4 recovery. And so that is probably the part of the study that I'm most excited for at this time, Dr. K. But nonetheless, very nice to see this preliminary data from our first 23 patients.
It's a small study, but a fascinating study. And it's really a concept. It's just thinking of a concept. I'm so pleased that you were able to get this so far. I was hoping, looking at future, looking at future direction. I know that there are other people like Dr. Durand from there who's also very interested in the soluble GP120. Would you take us beyond in the future direction? I know she's looking at a study where cardiovascular health is concerned and soluble GP120. Would you just walk us through to what you know about that study?
Yes, Dr. K, you're talking about the Restart study, and I'm so excited to hear about that. That is being led by Madeline Durand and Andreas Vinci. They're working in collaboration together, and they're basically looking at the effect of fostemsavir on coronary plaque, really, in people with HIV, the impact of fostemsavir on just cardiovascular health. What I think is so cool, though, about that study, Dr. K, is that they're actually using soluble GP120 assays for people to screen into the study. And so people with HIV, only those who have detectable soluble GP120 will be allowed to come into that study. And the primary outcome of that study is the coronary plaque burden as assessed by CT scan. And so again, that is what a primary example of taking it beyond viral suppression really looks like, right? Because we know cardiovascular disease is such an important comorbidity in our patients. And so anything that we're doing to try and see whether there might be new interventions to address the burden of coronary vascular disease in our patients is an important one. We have the REPRIEVE study that is well known and described to all of us in our fields, but I think this is going to be a really important companion study, and hopefully we'll see some important questions, answered. So speaking of soluble GP120, Dr. K, I'm curious to hear from you now, because I will tell you, in the RECOVER study, what I haven't actually said in that poster is that there are two groups of responders in that study. There are people that are hyper responders that have very large increases in CD4 T cell count with fostemsavir on board. And then there are people that don't respond at all. And so that result that you're seeing is just really being driven by both of those groups, and they're meeting in the middle. I have a sneaky suspicion that soluble GP120 levels, different levels, are driving that response. What do you think? Because those two phenotypes are kind of like those early and late viral responders that we talked about in BRIGHTE. It's not that everyone's having some sort of moderate response and recover. People are either responding very robustly or not at all.
What I'm more fascinated with is that and you had alluded to that earlier on, that even when your viral load is completely undetectable, you can have soluble GP120 floating around, wanting to stick to healthy CD4 cells. That's what I've really begin to appreciate more and more about this. I'm so glad people like you and so many other people are beginning to work on this, and that'll help us as clinicians see what to do beyond viral suppression in people who remain with low CD4 counts despite being completely undetectable. And I'm so grateful that so much of work is being done into it. And maybe for a future podcast, Dr. Rolle, you and I can do it, looking at some of the newer agents that have been approved by the FDA. Lenacapavir and iblisumab has been there in the market for some time, to look at what it can do. I don't think I know the data yet on that, what it could do regarding immunological recovery. So it's wonderful to spend this time with you. Thank you.
Thank you so much for having me, Dr. K. And I'd
Thank
be
you.
really excited to come back for a future podcast with you.
Thank you.
That would be wonderful. Thank you so much, Dr. Rolle and Dr. Kumar, for this wonderful conversation on these intriguing theories and ideas and the latest data. Thanks to our listeners for joining in. If you want to see more on this program, and if you want to see more details on these studies, we have slides available as well. So just click on the show notes and you'll get lots more information and lots more of this larger program. That's all for now. Thank you so much, and we'll see you on the next podcast soon.